Hi everyone, welcome to this week's lecture on the application of genomics to medicine and individualized healthcare. Genetic screening in populations is a population-based method designed to identify individuals with increased susceptibility to specific genetic diseases. This approach is distinct from testing individuals already identified as affected or as carriers through family history, as discussed in Chapter 17. While family history can be a useful tool, it has significant limitations. It provides only indirect insights into genetic susceptibility, as relatives, except for identical twins, do not share all genetic variants. Additionally, family history relies on the presence of overt disease in relatives, making it an insensitive indicator for identifying genetic risk. The significance of population-based genetic screening lies in its ability to directly and comprehensively evaluate an individual's genetic risks, independent of family history, offering a more precise approach to understanding genetic predisposition to disease. Genetic screening, while valuable, faces several challenges. First, accuracy is critical. False positives or negatives can lead to unnecessary anxiety or misdiagnoses. Ethical concerns also arise, such as ensuring privacy, obtaining informed consent, and preventing genetic discrimination in areas like insurance or employment. Population diversity is another issue. Genetic markers can vary significantly across groups, making findings less universally applicable. Family history, though a useful tool, has limitations. It's not sensitive enough to capture all genetic risks, since not all variants are shared among relatives. On the practical side, implementing large-scale screening programs involves high costs and logistical hurdles, including ensuring equitable access for all. Lastly, interpreting results can be complex, often requiring follow-up testing and genetic counseling to provide meaningful insights to individuals. Addressing these challenges is key to maximizing the benefits of genetic screening. Newborn screening is one of the most well-known and impactful genetic population screening programs. These initiatives, often government-supported, aim to detect diseases in pre-symptomatic infants, where early intervention can either prevent or significantly mitigate health impacts. Typically, this involves testing blood from a heel stick for abnormal biochemical markers. However, some screenings, like those for hearing loss and cardiac disease, directly assess phenotypes. These conditions are now included in the U.S. federally recommended uniform screening panel and adopted in other countries as well. Newborn screening tests must meet rigorous criteria for clinical validity and utility. An effective test minimizes false negatives to ensure no affected infants are missed. At the same time, false positives must remain acceptable to prevent undue parental stress and additional costs. Striking this balance is critical to the success of these programs. We will now discuss some conditions in detail. Phenylketonuria, or PKU, serves as the prototype condition for neonatal screening programs worldwide. The mainstay of screening involves analyzing a spot of blood on filter paper for elevated phenylalanine levels shortly after birth. This method is widely implemented across North America, Europe, Latin America, and much of Asia Pacific. When a positive result is confirmed, dietary phenylalanine restriction is introduced early in infancy, effectively preventing irreversible intellectual disability. Congenital hearing loss and hypothyroidism are two widely targeted conditions for newborn screening. Hearing loss screening is mandated throughout the United States and Canada, with approximately half of congenital deafness attributed to single gene defects. Early interventions, such as sign language and cochlear implants, significantly improve language and intellectual development. For hypothyroidism, routine screening is universal in the US and Canada and available in many other countries. Early thyroid hormone replacement therapy prevents the severe intellectual disability associated with this disorder. In addition to PKU, hearing loss, and hypothyroidism, many newborn screening programs target other disorders such as galactosemia, sickle cell disease, and severe combined immunodeficiency. In the U.S.A., the Recommended Universal Screening Panel, or RUSP, provides national guidelines for testing. However, global standards differ significantly. For instance, Canada lacks a national consensus, with screening protocols varying by province. In the United Kingdom, the National Newborn Screening Program includes just 9 disorders as of 2022. Tandem mass spectrometry. For many years, newborn screening relied on individual tests for specific conditions, such as phenylketonuria (PKU). With the advent of tandem mass spectrometry, or TMS, this process has been revolutionized. TMS allows a single neonatal blood spot to be analyzed for multiple biochemical disorders simultaneously. This technology not only enhances accuracy, reducing false positives, but also expands the range of detectable disorders. For instance, TMS can screen for amino acid disorders like PKU, homocystinuria, and maple syrup urine disease, organic acid disorders such as methylmalonic acidemia, and fatty acid oxidation disorders like MCAD and VLCAD. Tandem mass spectrometry has significantly broadened the scope of newborn screening, detecting dozens of biochemical and metabolic disorders quickly and effectively. However, TMS does not replace disorder-specific tests used for conditions like galactosemia, biotinidase deficiency, congenital adrenal hyperplasia, or sickle cell disease. By complementing traditional methods, TMS ensures a more comprehensive approach to newborn screening, improving early diagnosis and treatment outcomes for numerous conditions. Tandem mass spectrometry, or TMS, provides a reliable method for newborn screening of disorders like MCAD deficiency, which previously lacked effective screening programs. MCAD deficiency is a fatty acid oxidation disorder that is typically asymptomatic, but can cause life-threatening hypoglycemia during catabolic stress, such as a viral illness. Without early detection, up to 25% of children with undiagnosed MCAD deficiency die during their first hypoglycemic episode. Screening at birth allows parents and physicians to manage the condition by avoiding prolonged fasting and addressing metabolic stress promptly. While TMS expands newborn screening by detecting rare disorders like methylmalonic acidemia and asymptomatic conditions such as SCAD deficiency, it does raise challenges. For instance, SCAD deficiency is typically asymptomatic, meaning a positive result might not predict future health issues. This creates unnecessary concern for parents. Public health experts argue that only metabolites with proven clinical relevance should be reported, ensuring that the focus remains on conditions where early detection provides clear benefits for the child's health. Pharmacogenomics. Pharmacogenomics is the study of how genetic variations influence an individual's response to medications. By using a genetic profile, healthcare professionals can predict the effectiveness or toxicity of a drug, reducing adverse events and ensuring adequate therapy. For example, a genetic test can guide the selection or dosage of a medication to provide the best outcome for the patient. Many gene-drug combinations are now recognized by the FDA, with pharmacogenetic information included in drug labels. For instance, variations in the Ch.19 gene can influence the effectiveness of clopidogrel, a blood thinner. Similarly, CYP2D6 affects the metabolism of drugs like codeine and tamoxifen, while HLA 5701 helps predict hypersensitivity to abacavir. These examples show how pharmacogenomics is shaping personalized medicine. Genetic variation affects drug therapy in two main ways: pharmacokinetics and pharmacodynamics. Pharmacokinetics refers to how the body processes a drug, such as how CYP2C9 impacts warfarin and metabolism. Pharmacodynamics, on the other hand, involves how the body responds to a drug, such as how VCORC1 variations alter warfarin sensitivity. Together, these insights guide more precise and effective treatment plans. Variation in pharmacokinetic response. The cytochrome P450 family of enzymes metabolizes the majority of drugs we use, with key contributors like CYP2C9, CYP2C19, CYP2D6, and CYP3A4. These enzymes either detoxify active drugs or activate prodrugs to exert therapeutic effects. Genetic variations in these CYP genes affect enzyme activity, resulting in different drug metabolism rates and ultimately variations in drug response. Variants in CYP2D6 produce distinct metabolizer phenotypes, including normal, poor, intermediate, and ultra-fast metabolizers. For example, poor metabolizers of codeine receive little therapeutic benefit due to a lack of conversion to morphine, while ultra-fast metabolizers are at risk of toxicity from rapid conversion. These differences highlight the importance of understanding genetic variations in drug metabolism. Here is an example for codeine and what a poor metabolizer versus an ultra-fast metabolizer looks like. Poor metabolizers will have minimal therapeutic effect and will gain no benefit from the drug. On the other hand, ultra-fast metabolizers have a risk of toxicity due to the rapid conversion of codeine to morphine. Population differences in metabolizer phenotypes significantly impact drug therapy. For instance, 7.2% of Europeans are CYP2D6 poor metabolizers, while this phenotype is rare in Asians and Native Americans. Similarly, slow CYP2C19 metabolism is much more common in Asians and Pacific Islanders. Such variability highlights the importance of tailoring drug therapy to individual genetic and ethnic profiles. Clinical pharmacogenetics aims to integrate genetic data into drug therapy decisions. Organizations like CPIC and DPWG have established guidelines for consistent application of pharmacogenetic data. The FDA also recognizes its importance, including this information in drug labels. However, further cost-effectiveness studies are essential for broader adoption in clinical practice. Variation in pharmacodynamic response. Malignant hyperthermia is a rare but severe adverse drug reaction triggered by certain anesthetics, such as halothane, or muscle relaxants like succinylcholine. It causes a dramatic increase in body temperature, sustained muscle contractions, and rhabdomyolysis due to elevated calcium levels in muscle cells. While the most common cause is a variant in the RYR1 gene, other genetic loci such as CACNA1s are also implicated. Malignant hyperthermia is a rare cause of death during anesthesia, with a higher incidence in children. Management involves the use of cooling blankets, muscle relaxants, and cardiac antiarrhythmics. Pharmacogenomics guidelines also assist clinicians in tailoring anesthesia to avoid triggering an adverse reaction. Adverse drug reactions fall into two categories: predictable, such as overdoses or drug interactions, and unpredictable, often involving genetic factors. Hypersensitivity reactions can be IgE-mediated, such as anaphylaxis, or genetically determined non-allergic immune reactions, such as Stevens-Johnson syndrome and toxic epidermal necrolysis. Genetic screening plays a vital role in preventing severe adverse drug reactions like Stevens-Johnson syndrome and toxic epidermal necrolysis. For example, HLA-B 5701 typing is now a standard practice to avoid hypersensitivity to abacavir, as it offers a 100% negative predictive value. Similarly, HLA-B 1502 typing helps reduce risks with carbamazepine. While many pharmacogenomic studies focus on single gene variations, drug response is often a complex trait influenced by multiple genetic and environmental factors. Drugs may act through active metabolites, processed by different pathways, with genetic variants at various loci interacting to modify effectiveness or toxicity. Environmental factors, disease states, and drug interactions further contribute to this complexity. The ultimate goal of pharmacogenomics is to create a comprehensive profile to guide personalized therapy. ensuring that each patient receives the most effective drug at the optimal dose while avoiding adverse effects. As research progresses, pharmacogenomics is poised to play an increasingly significant role in precision medicine. Screening for genetic susceptibility to disease. Genetic epidemiology focuses on the interaction between genotypes and environmental factors in influencing disease risk. Study designs include case control studies, which compare individuals with and without disease, cross-sectional studies that take a snapshot of the population, and cohort studies that track individuals over time. Each design provides unique insights into disease prevalence and genetic risk. A genetic disease association examines the link between a genotype and disease. For example, the APCP, IL-1307 Lias variant, is associated with a 2.4-fold increased risk of colorectal cancer. Predictive testing measures the likelihood of disease development in individuals with or without a susceptibility genotype, captured by positive and negative predictive values. Clinical validity refers to how well a genetic test predicts disease. For instance, APOE4 heterozygotes have a 2 to 3 times increased risk of Alzheimer's, while homozygotes face an 8 times risk. However, low positive predictive value in asymptomatic individuals limits the utility of such testing. Clinical utility evaluates whether a genetic test result informs actionable medical care. For example, HFE testing for hereditary hemochromatosis enables preventive interventions like phlebotomy, despite low positive predictive value. In contrast, APOE testing for Alzheimer's has limited utility due to the absence of preventive treatments. The predictive value of a genetic test depends on the disease prevalence, genotype frequency, and relative risk. Rare genotypes that confer high relative risk are more valuable as predictors than common genotypes with lower risk. Genetic testing raises ethical concerns, such as the psychological impact of knowing one's susceptibility and the false reassurance of a negative result. For instance, APOE testing for Alzheimer's can cause distress due to limited actionable outcomes, making careful counseling essential. As genetic testing evolves, its utility must be continually reassessed with the development of new preventive and therapeutic options. The ultimate goal is to integrate genetic testing into personalized care, improving outcomes and enabling precision medicine. Carrier screening examples. This slide highlights the impact of carrier screening in reducing the prevalence of genetic disorders. It provides examples such as Tay-Sachs disease, where screening has significantly decreased incidence in Ashkenazi Jewish populations, and cystic fibrosis, where screening is a standard practice for couples planning pregnancy. Key success factors include community engagement, access to prenatal diagnosis, and genetic counseling, which help ensure the effectiveness of screening programs. However, challenges remain, such as limited impact in certain populations, exemplified by sickle cell disease in the U.S., due to barriers in screening accessibility and uptake. Advances in next-generation sequencing now allow for expanded carrier screening, detecting over 400 genetic conditions. While this increases sensitivity, it also uncovers variants of uncertain significance, underscoring the need for careful interpretation and validation. Individualized genomic medicine leverages whole genome sequencing to identify nearly all DNA variations, enabling the detection of rare disorders and insights into common conditions like autism or cancer. As this technology evolves, WGS is expected to become the gold standard in precision medicine. Precision child health represents a transformative approach to pediatric care, integrating genetic, biological, environmental, and patient-reported data for targeted disease management. By harnessing tools like bioinformatics and advanced analytics, it promises faster, cost-effective diagnostics, safer therapies, and improved preventive care. This innovative strategy has the potential to revolutionize healthcare delivery, decreasing preventable harm and advancing patient-centered care across all areas of medicine. Please email Pansma if you have any questions.